Welcome back. Welcome back to another edition of Journal Club with Hirad at Hirad EP YouTube channel. Today we're going to talk about 4 important papers published in month of July in 2022 in regards to management and treatment of atrial fibrillation. And let's start. Alrighty. Okay, let's get to the first paper. The first paper is published in Journal of American College of Cardiology. The title is Presenting Pattern of Atrial Fibrillation and Outcomes of Early Rhythm Control Therapy. This is a pre-specified secondary analysis of East AFNet-4 trial, which was published last year and is basically early treatment of atrial fibrillation for stroke prevention. They wanted to look at the impact of different presentation of atrial fibrillation at the time of diagnosis on outcomes of treatment. So they had 3,000 patients, give and take, and divided to 3 categories of atrial fibrillation. One was the first diagnosis of atrial fibrillation. Those are the patients that enroll 7 days after the first clinical diagnosis of AFib, so 7 days after it was diagnosed. The second group and the third group, paroxysmal AFib and persistent AFib, they are more chronic arrhythmia categories. So first diagnosed acute, paroxysmal, and persistent chronic. And they would define it as diagnosis of atrial fibrillation within the last year and the persistent more than a year. So they followed these patients and for median follow-up of 5.1 years, and they looked for outcomes of cardiovascular death, stroke, hospitalization for heart failure, or acute coronary syndrome. So this is a primary composite outcome, all 4 of these: cardiovascular death, stroke, hospitalization for heart failure, or acute coronary syndrome. And they look at see if the early rhythm management, including ablation treatment, catheter ablation, as well as rhythm medications, can affect the outcomes when they compare to control therapy, which is just basically rate control management of atrial fibrillation. So what they noticed that all groups in first diagnosis of AFib and paroxysmal and persistent presentation, all 3 groups, they found that there is a decrease in statistical significant decrease in primary outcomes of cardiovascular death, stroke, heart failure, hospitalization, and acute coronary syndrome. However, what they notice in the group of the acute arrhythmia, first diagnosis of AFib, we have less of this effect, and we see more hospitalization for heart failure, more acute coronary syndrome, and also less improvement in quality of life when we do early rhythm control therapy with oral anticoagulation. To explain this finding, they mentioned that maybe acute arrhythmia is a proxy for some sort of critical illness, and that's the reason the usual treatment for arrhythmia, of atrial fibrillation arrhythmia, doesn't provide the same effect in these different categories of manifestation. But anyway, overall, any patient, both groups benefit from early rhythm control therapy. The benefit in acute arrhythmia group was less, as you see the differences. The other interesting point that we notice here is we have some evidence now as well, again, that the treatment with rhythm control treatment can decrease the rate of stroke in these patients, which is most likely because of restoration of sinus rhythm, and that will prevent from arrhythmia as well as stroke from it. All right, so let's go to the next paper. Okay, let's get to the second paper. This is a paper published in Heart Rhythm Society Journal in July, of course, July of 2022. The title is Catheter Ablation Improves Outcomes and Quality of Life in Japanese Patients with Early Stage Atrial Fibrillation, a retrospective cohort study. So they used the contemporary Japanese registry, and they identify 823 pairs of patients. They extract these 2 pairs of the patients that underwent catheter ablation versus medical therapy. All of these are newly diagnosed, so they focus on early treatment. They follow these patients for a median of 2 years, and they look at outcomes like all-cause death, stroke, bleeding, and heart failure hospitalization. So that was a composite outcome they looked. Also, they look at quality of life and see if there's anything different they can observe. So after follow-up for 2 years, as you see here, there's a significant difference between the group that got catheter ablation versus medical therapy, and has a ratio of 0.49. Some interesting findings that you can notice here: after 12 months, around 1 year, it starts to open more, and they diverge further and further with time goes by. And this is interesting comparing to the previous paper that we talked. This is only catheter versus other rhythm management. When they looked at, so this is a primary composite outcome, but when they looked at all the subgroups of outcomes, different segments of the outcomes, like all-cause death, stroke, bleeding events, and heart failure hospitalization, what they notice, the only one that is significant is heart failure hospitalization. So basically, it seems that heart failure hospitalization is driving the whole thing. The whole thing is basically driven by the heart failure hospitalization. And what is interesting is was not part of the Cabana trial in the primary outcome. And another thing is they use patients with newly diagnosed versus patient not all comers like Cabana. So what they deduced is early treatment of atrial fibrillation with catheter ablation will improve the composite outcome, and specifically heart failure hospitalization. As well, they show the quality of life improves in patients that get catheter ablation. Very good, thank you. Okay, let's get to the third paper published in JACC EP. The title is Circumferential Pulmonary Vein Isolation plus a Low Voltage Area Modification in Patient with Persistent Atrial Fibrillation. This is stable sinus rhythm 2 trial, and this is a randomized trial, of course. 300 patients with persistent atrial fibrillation de novo were randomized to 2 groups. One group only get a pulmonary vein isolation, and the second group get pulmonary vein isolation as well as substrate modification if they have a low voltage area or scar area. They define the low voltage area scar area in a little bit of particular pattern. So if the voltage mapping in sinus rhythm shows their area less than 0.1 millivolt, they call it dense. 0.1 to 0.4 we'll call low voltage area, and 0.4 to 1.3 we'll call transition zones. And basically they follow these patients for 18 months. They look at outcome of freedom from atrial arrhythmia, including atrial fibrillation, atrial tachycardia, that is more than 30 seconds after the blanking period of 3 months. And so then they look and see if there's any differences with the outcome of the recurrence if you do substrate modification or not. So let's see. Why is not coming? There you go. So this slide shows how they modify during sinus rhythm. They map it. They found the complex EGMs here. They found the area of a scar tissue either in the anterior and posterior wall. They tried to modify it and connect it to the lines here. So that was a part of the scar modification. And then at the end, they found there was no difference between these two groups in the recurrence of AT and AFib. And as you see in back in 12-18 months, we have 70% of patients that they don't have any recurrence, which is really good in a patient with persistent AFib. About 50% of the patients in persistent AFib in this group had scar low voltage area. And they found if you don't have a low voltage area versus having a low voltage area, you will have a significant difference in your success. So 85% of patients with no voltage area didn't have any AFib when they follow for 18 months. That shows how important is scar tissue, low voltage area in the outcome of AFib ablation. As you know, we always had a problem with persistent patient comparing to a paroxysmal patient for the outcomes. Now it shows that if your voltage shows something good, you might have as good as outcomes of a paroxysmal AFib ablation. And what the other interesting thing is, if you have a low voltage area, two groups that both have a low voltage area, does modification improves the outcome? As the p-value here shows not, but there is some trend, and you see the percentage is 65% versus 56%. So there might be some small benefit with the substrate modification, maybe in some subgroups that we need to investigate more. And this is in line with other papers, especially recent decaf paper, show the same thing, that substrate modification going after the scar tissue or low voltage area not necessarily improve the outcomes of ablation. Great. So time to go to the fourth paper and the last paper. All right, let's do that. Okay, let's get to the last paper of this session, and this is a paper published in Europace. The paper titled Esophageal Safety in Voltage Guided Atrial Fibrillation Ablation Using Ablation Index or Contact Force Only, a Prospective Comparison. So this study basically compared two groups, 100 groups of the 100 patients in the contact force group, and another 100 patients in ablation index group. Ablation index group was guided by the ablation index of the lesions. So basically, in ablation index group, they made sure that the inner lesion distance is less than 6 millimeters, so there's not big gap, and they use ablation index more than 500 anteriorly and ablation index more than 350 to 400 posteriorly. And they use the standard traditional conventional way of ablation. They use about like a 30-35 watts anterior wall and 20 to 25 watts in posterior wall, not the high power short duration that some of us use for AFib ablation. Now, when they follow, basically 1 to 3 days post ablation, they did endoscopy, and they look at how many of the patient had injuries of esophagus. There were two categories. Category 1, the ulceration was less than 5 millimeter, and category 2, more severe, more than 5 millimeter ulceration. And they found there's no difference. So 6 patients in this group and 5 patients in another group had this problem, and both basically developed mild and severe injury. However, you see that the stronger, more severe form of injury happens in the contact force group. And also they found the predictors of the injury, especially category 2, was if the AI index was more than 520, or also patients with cardiomyopathy, if you do ablation of posterior or roof lines, as well as low body mass index. And they concluded that if your ablation index stays about 400 to 450, you still have benefit from your efficacy, and you might have more safety with your esophagus. So that was the message of this paper. Alrighty, thank you very much for listening and watching this. Stay tuned for the next edition. Bye-bye.